Ready, welcome to Module 8. This is Ischemia and Infarction. This is going to be our last content module, and then the next ones in the series are going to go over more of practice problems and things like that to help you out. But let's talk about some EKG findings. With ischemia, we're going to really be looking for those inverted T waves or that flat and downsloping ST segment depression. Whereas in an infarction, we're looking for the classic ST elevation, the T wave inversion, or the large Q waves in the zone of infarction. Now, it's really important here that we're looking at changes in multiple leads. We're given a full 12-lead EKG in most of these cases, so we need to use all of that information to our advantage. Acute myocardial infarction, or MI, typically causes ST elevation in 2 or more contiguous leads. And so if you were looking at this picture and we only see ST elevation in one lead and it's not in the other leads that we would expect it to be paired with, then we might be thinking this is ischemia rather than infarction. And so we need to use all of this information and this complete picture to really help our understanding of what is going on inside the heart. I think this diagram is interesting as well, just to kind of go over the timing of EKG changes and how they might appear. And this is a little bit broader than maybe the first couple minutes and hours breaks down. But the key points I want to kind of point out here are the tombstone that we see when we have our extensive injury or our infarct. The tombstone is the really classic sign for ST elevation, kind of at its peak that we would see. And then the other part that I want to point out is this Q wave is going to persist long after, weeks or months after someone has had an infarct. And so you might be working in emergency medicine and you get an EKG and they've got deep Q waves. Well, you might want to suspect they have a heart history or something along those lines. All right, let's talk some definitions. We have unstable angina, STEMI, and NSTEMI. So unstable angina, these all start with the same thing. You have some sort of rupture of a plaque. You build up and then you have rupture. Now with unstable angina, you're going to have incomplete occlusion. So you're not going to have an appreciable infarction. Therefore, EKG, we're not really expecting to see anything, and the cardiac biomarkers are not going to be significantly elevated. Whereas in NSTEMI, or non-ST elevation myocardial infarction, same thing, we've got the plaque rupture. We also have that incomplete occlusion, but we're going to have a subendocardial infarction. That's the key difference here, okay? So we may not see that ST elevation still, but when we look at our cardiac biomarkers, they are going to be elevated. So when you measure your troponin, you're going to see a bump in the troponin. It's going to go up. And then last we have STEMI. Again, we start with the plaque rupture, but here we have a complete occlusion and a transmural infarction. So that EKG, we talked about this a little bit. We have the peaked T waves, we have the ST elevations, we have the deep Q waves, and those cardiac biomarkers may or may not be significantly elevated in this case. I think this diagram is helpful to kind of walk through it when you're trying to consider which one is which. So first thing you need to ask yourself, are there ST elevations on the EKG? If there are, congrats, you figured it out, you have a STEMI, okay? If there aren't, then you need to ask yourself, okay, is their troponin elevated? And if it is, congrats, you figured it out, you have an NSTEMI. And if it's not, that's okay. Ask yourself, does the chest pain improve with rest or nitroglycerin? If it does, you have stable angina. And if it does not, you have unstable angina. And I want to go through that again because I think it can be a little bit confusing. So in order to have unstable angina, you did not have ST elevations, you do not have an elevated troponin, and your chest pain does not improve with rest or nitroglycerin. That gives you unstable angina. This is what we were talking about earlier a little bit with the reciprocal leads. So, for example, if you saw ST elevation in leads 2, 3, and AVF here, we've got that little tombstone that we're looking for, right? So we see the ST elevation, we see it's in these contiguous leads. These are leads that we expect to go together. Now, the other thing that we're going to look for, again, we've got 12 little pictures here, so let's use it to our advantage. The reciprocal of the inferior lead is going to be our lateral leads. And what we mean by reciprocal is in our inferior leads here, we expect it to be ST elevation. In our reciprocal, we're going to expect depression. So see how if you were to, flip this upside down, it would look like essentially what the inferior leads do look like. But we don't do that. So instead of ST elevation, we're expecting that ST depression in all of our lateral leads. And it might be more pronounced in some than others. That's just kind of the way things go. It tells you more about the location. So don't necessarily say, oh, well, it's hardly depressed over here, so that's not a reciprocal change. Remember, we have 12 pictures, so use all of the pictures to your advantage. And then lastly, I just wanted to go over the blood supply a little bit again as a refresher. So that 2, 3 in AVF here, we're going to see the RCA or the left circumflex. For our lateral leads, we can see the left circumflex or diagonal branch of the LAD. And then for our septal and anterior leads, we're really going to see the LAD be the number 1 here. And I think this is a helpful diagram to just kind of walk through the different branches as well and see the supply of the heart. All right, that's all I got for you. We are going to go into some practice next. Again, if you have anything else that you want to go over in this series, please just let me know in the comments. I'm happy to make more content for you. This is the end of what I have planned so far for content, but that absolutely does not mean that we cannot make more videos, and I plan to make some more on other topics as well. Alrighty, take care. Good luck studying. You got this.